All right. Hi, everyone. Welcome to our MIDAS webinar for August. My name is Jessica Salerno. I'm the project coordinator for the MIDAS network. For those of you who are new to the MIDAS network webinars, MIDAS is a network of infectious disease modelers with over 500 members worldwide. We open our membership to any infectious disease scientist, practitioner, or student who supports our mission and vision. Membership is free, and you can learn more about our network and opportunities within our network and membership at our website, which is midasnetwork.us. And I'm very excited to introduce our speaker for today, which is Dr. Kaja Abbas, who is joining us from Korea at 1 a.m. So thank you so much for being here. Dr. Abbas is an assistant professor of disease modeling at the London School of Hygiene and Tropical Medicine. He completed his postdoc at Virginia Tech, and he has been a MIDAS member for a very long time. His research area is vaccine impact modeling, with a focus on estimating the health, economic, and equity impact of vaccination programs. His specific projects include estimation of the health impact of human papillomavirus vaccination at the global, regional, and national levels, equity impact of childhood vaccination in Ethiopia, cost effectiveness of the Haemophilus influenzae type B, pneumococcal, and rotavirus vaccination in Sudan, and benefit risk analysis of routine childhood immunization during the COVID-19 pandemic in Africa. So Dr. Abbas, why don't you go ahead and get started?
Thanks, Jess. Yeah. Are you able to see my screen?
Yes.
Okay, great. Wonderful. Thanks, Jess, and welcome everyone. It's a pleasure to meet all of you virtually. And so finally, today the presentation will focus on the vaccination impact, the effectiveness, the efficiency, and equity impact of vaccination. And with respect to the effectiveness, we look at the health impact of the human papillomavirus vaccination at the global, regional, and national levels. And with respect to efficiency, we will look at the value of HPV vaccination, wherein we add the cost on top of the health impact. Specifically, we can focus on Gavi eligible countries. And also we look at the cost benefit analysis of dengue vaccination. And with respect to equity impact, we look at the impact of vaccination for equity in the context of Ethiopia. And in the context of the ongoing pandemic, we will look at also the benefit risk analysis of sustaining routine childhood immunization during the COVID-19 pandemic in the context of Africa, but it's broadly applicable to other areas as well. Currently, there are roughly around more than 500,000 cases of cervical cancer, and among deaths, almost 300,000 deaths that occur among women, of which 90% of those deaths actually occur in low and middle income countries. And the current
can I interrupt? Sorry for interrupting. We're still seeing your first slide, and also can you maximize it? We just see the PDF, kind of the Acrobat program with the sidebars and everything.
Oh, okay. How about now? Are you able to see the screen?
Yes. This is good. Yeah, thanks.
Okay. So, okay, great. Yeah, and okay. So there are roughly more than 500,000 cases of cervical cancer annually, and more than 300,000 deaths, of which more than nearly 90% of those deaths actually occur in low and middle income countries. And among the vaccines that are currently available, the bivalent and quadrivalent, They protect against the strains of 16 and 18, and the non-valent, the newer vaccine, actually protects against 5 other strains. So the main risk type 16 and 18, they cause roughly around 70% of all cervical cancers. And adding the other 5 other high-risk strains, they cause roughly another almost 20% of other cancers. And if we do, in 2018, basically WHO Director General came up with a cervical cancer elimination strategy, wherein he would like to potentially see, within this generation, elimination of cervical cancer as a public health problem. And primarily done through 3 means. One is by scale up of HPV vaccination, and then availability of screening tests, and as well as treatment and care. And the proposed targets by 2030 is roughly around 90% scale up of HPV vaccination among girls by 15 years of age, and with respect to screening at least twice in their lifetime, and with a 70% coverage, and around a 90% coverage for treatment who do get diagnosed with cervical cancer. So in the context of this, primarily we are looking at the health impact of HPV vaccination in around 177 countries, which pretty much covers most of the global population. And the scenario we are looking at aligns with this particular strategy, wherein we are looking at around a 90% vaccination coverage among 9-year-old girls, and during a 10-year period from 2020 to 2029. So the model that's currently being used is a static model. It's basically a proportional impact model. So the way it works is by looking at the burden at a corresponding age in a corresponding country. And then we look at, this is all cervical cancers. And then we look at the country-specific proportion of cervical cancers in that particular country. And then basically we apply the vaccine coverage and then the vaccine efficacy in that particular country and area. And then also we presume that the vaccine is only able to provide protection among women who have not experienced sexual abuse. So what we get is a kind of a conservative estimate of the vaccination impact. So by doing this, we can estimate what is the burden that's averted at a particular age. Thereby, in the absence of vaccination, this would have been the corresponding burden among those different birth cohorts. For example, in the birth cohort of roughly around say 2020, basically throughout the lifetime, around different age groups, what is the burden of cervical cancer? With the bivalent vaccination, this will be the corresponding reduction in burden among this particular cohort. So this is the 20-, 9-year-olds who get vaccinated, and then through the lifetime, what is the reduction in cervical cancer? And then along with this, for each of those years, like from 2020 to 2029. And then if we apply the monovalent vaccination, the impact is relatively much more larger than the bivalent vaccine, and this will be the corresponding reduction in cervical cancer. But that being said, we get a much larger reduction in monovalent vaccine. That's primarily because we are only looking at the direct effects, and cross protection and indirect effects are not taken into account. If we do take cross protection and indirect effects of the bivalent vaccine account, the effect of the bivalent vaccine is relatively much larger than what we see up here. And then this is the impact on the cases, and here is the corresponding impact on the deaths, and then this is the corresponding impact on disability adjusted life years. And each disability adjusted life year, you can think of it as a loss of 1 healthy life year. So this is at the global level. And when we look at the regional level, the number of cases that can be averted per 1,000 vaccinated girls, the largest impact is in the African region, and the least impact is in the Eastern Mediterranean region. And the reason being, even though 1,000 vaccines are deployed, like per 1,000 vaccines, and even though the vaccine efficacy does not change between region to region, the underlying disease burden in different countries are different. And the largest burden is actually in the African region, which is why for each vaccine that is delivered, the largest relative impact that we can gain is basically in the African countries. Thereby, since the burden is much larger in sub-Saharan Africa, those are the countries that should have been prioritized for vaccination. But what we have is a kind of a topsy-turvy. Countries which have actually low burden and much high income countries, they have introduced the vaccine first, like UK and the US and so forth, more than 15 years before, while still a number of countries, even today in Africa, have not introduced the vaccine. And even among the countries that have introduced the vaccine, only a few, like the coverage is still not that high enough in comparison to the low-income countries. And this is impact of the bivalent vaccine. Similarly, we can estimate the impact for the monovalent vaccine, and here primarily the impact will be a little more higher compared to the bivalent vaccine because it also covers 5 more strains. But yeah, and that's a corresponding impact with respect to cases averted, deaths averted, and DALYs averted. And correspondingly, we see the similar trend wherein the countries in Africa will stand to gain the most. Thereby, with respect to the limitations, one is herd effects, like indirect effects were not considered. And also we have put in a conservative estimate of like the vaccine has no effect on females after sexual debut, which is not real either. But even with all of this limitations put together, still what we do see is that HPV vaccination is quite a very effective program to reduce the burden of cervical cancer. By actually incorporating additional features like cross protection and indirect effects, the estimated impact will be even more larger than what we estimate here. So the implications being, since the burden of cervical cancer is high in the African region, these are the countries from an equity perspective, these are the countries that should have been prioritized first because high burden should be prioritized. But what has happened is actually the lower burden countries have been getting the vaccine first, and this is something that we'll have to think about as we go about introducing the COVID vaccine in the near future as it gets licensed. But with respect to HPV vaccination moving forward, at least countries in the Africa region should be prioritized for both introduction and among countries that are introduced, scale the coverage to much higher levels. So we looked at the health impact. Now adding costs on top of it, and here we specifically focus on 46 Gavi eligible countries and a similar vaccination scenario of 90% coverage for the 10-year time period of 2022-29. So here we primarily look at, in contrast to the regular cost effective analysis, here what we try to estimate is a net health impact. So to understand this is going to be the impact of HPV vaccination. So what is happening is before and after, what is the number of healthy life years gained by implementing HPV vaccination in a specific country. And then it's going to cost. In order for it to cost, with the cost that is used to implement a vaccination program. So before vaccination, with respect to cervical cancer, we have treatment costs. After vaccination, now it's going to be like after vaccination, we have the vaccination cost, but correspondingly there is a reduction in the cervical treatment cost because the number of cases should come down. So that's the difference for the net cost. And then we look at the country-specific estimate, how much it costs to avert a single DALY or how much it costs to avert the loss of a single healthy life year. So that is based on the set of health services that are provided in that particular in a given country. Thereby, the net health impact of introducing HPV vaccination with the same set of resources, if you were to apply those resources into the current health system, this is how the health impact of that particular intervention, the current health system without those resources. So if we introduce HPV vaccination, the impact should be positive, the net health impact. If it is not positive, what it indicates is that we have replaced or taken resources that are much more efficient and applied them to HPV vaccination. So even though HPV vaccination is beneficial, those resources could have actually gained much more larger impact on other existing health services. So that's the key idea, like in a sense, to have a positive net health impact. So when we look at, for example, the current Gavi eligible countries, actually many of the countries with the current non-Gavi vaccine prices, they will actually replace health services that are much more efficient and it'll be replaced by HPV vaccination. For example, in this one of these countries we look at, you'll be replacing intervention that awards like 1,000 or gains 1,000 healthy life years with the HPV vaccination, which only gives you roughly around 100 life years. So that's not efficient. So in order to make it at least introduce the intervention such that it does not replace more efficient services, right now Gavi basically negotiates and provides country-specific subsidies so that the impact that the HPV vaccination can have in each country at least will be equivalent to what the resources are spent in a given country for to basically to gain one healthy life year. So that's the key idea. In a sense, when we introduce a new intervention, we don't want to displace more efficient interventions. The new intervention should be at least as efficient as other interventions that are currently deployed in a given country. So the key thing is basically, without, like at non-Gavi prices, HPV vaccination will actually have negative health benefits. So thereby at Gavi negotiated prices, for many of these countries now, HPV vaccination is actually offering a much more positive net health benefits. And then continuing with the efficiency aspects, here we look at the impact of dengue vaccination in the endemic settings of Southeast Asia and Latin America. And then in 2016, the dengue vaccine was licensed. And in 2017, it was introduced at the national level, especially in Philippines, and then as pilot studies in Brazil. But then by the end of even early 2018, there was a number of controversies to it. And since 2018, it has been suspended. So we look at it, why it's happening. So in dengue, there are primarily 4 serotypes. And the first infection actually will have a normal, like a much more milder reaction. But the second infection with a different serotype could lead to much more severe, like disease outcomes. Thereby, the vaccine from the clinical trial data, what we do infer is that the vaccine acts as a silent natural infection. Thereby, if you provide the vaccine to someone who has already been exposed to the first infection naturally, and then if they get vaccinated, the vaccine acts as the second natural infection. And then any further infections post-secondary, they are much more milder. Thereby, this is a very desirable scenario, the one in the bottom. On the other hand, if you provide the vaccine to someone who's seronegative, and then the vaccine acts as a first infection, and then following that they get a first natural infection will be a secondary infection, they have much more severe like disease outcomes. So the middle one is non-desirable, while the one in the bottom is desirable. But that being said, when the vaccine was introduced, there was no serological test to basically determine who's seropositive and seronegative, and then provide the vaccine. So thereby, as things stand, the vaccine has been suspended, and currently, like ongoing, like R&D research and development is going on to develop like point of care serological tests. So when the tests do become available, what we do want to have is someone who gets, like without the test, we could provide the vaccine to someone who has got the first infection and then provide the vaccine. Or we may miss out and give to people who are seronegative, and then the first infection will be much more severe. So this is the outcome that we want to avoid, while this is the outcome that we want to potentially have, where first natural infection and then the vaccine. So in order to implement it with the test, someone who gets the first infection, and then when you test them, they are seropositive, and then you provide them the vaccine. On the other hand, if someone is seronegative, you test them, and since they are seronegative, you do not provide the vaccine. And then you could test them repeatedly in the following years, and then whenever they become seropositive, it is then the vaccine is, if in they get the first infection, following that, you want to, with the seropositive status, you want to provide the vaccine before they get the second infection. So that's the key aspects. You want to provide the vaccine wherein someone who's seronegative we do not want to give them the vaccine. So the test will basically help to determine that anyone is seronegative, don't vaccinate. On the other hand, when you test provides the status as seropositive for someone who's already encountered the infection, you do want to vaccinate them so that it will have much more effective. Thereby, when we look at the impact of cost with respect to the vaccine cost, and when the vaccine was actually originally licensed, already it was at the cost effectiveness margin. Now, trying to add the test cost on top of it is going to make it even more like relatively less desirable and less cost effective. And then when we look at the test cost as a fraction of the secondary infection, especially severe hospitalization cost, if the test cost and the vaccine costs are as low as possible, it is much more desirable to have a positive return on investment, irrespective of the proportion of seropositive among 9-year-olds in this. For example, 50% are seropositive, or 70% by the time they hit 9 years. And then with respect to the number of tests, so again, like if the test costs are higher, then you want to vaccinate or you want to do the testing as early as possible in order to be more cost effective. While if the test costs are much more lower, then you can basically it will have a positive return on investment even when you test it at later ages. And with respect to the settings of more like, for example, in this case, we are comparing Peru and Malaysia. In Peru, it will be much more cost effective to implement the intervention because the hospitalization costs are almost 3 times the cost with respect to Malaysia to treat one single a hospitalized case of dengue. On the other hand, so depending upon the country, you could have different cost effectiveness thresholds at which it will turn out to be more cost effective. Thereby, in order to determine each country, so here's an app basically that kind of facilitates this process, wherein each country corresponding to their serological background, they could apply it and then try to determine the cost at which, by implementing the test and vaccination strategy, it will be cost effective and prices at which it will not be cost effective. So thereby, as things stand, dengue vaccine on its own cannot be given. So when the test becomes available, we want to implement the most efficient test and vaccinate strategies. And by doing testing, we can eliminate vaccination of seronegative individuals, which is undesirable. And then we can also potentially do instead of one-time test and vaccinate. If someone tests seronegative, potentially they could be followed up in the next year or a couple of years later to test, and then they can provide the vaccination. And then the current WHO guidance basically recommends the vaccine to be given only to ages 9 years and older. But when the tests do become available, this is a guidance that potentially needs to be revisited and potentially be revised. And tests can be done at younger ages, and children could be vaccinated at relatively younger ages as well. And with respect to looking at coverage and the equity impact, so here in the context of Ethiopia, we are looking at the vaccines that are given the first year of life, primarily the BCG vaccine, which is given at birth. Then we have the diphtheria, tetanus, pertussis, hepatitis B, hemophilia type B, which is the pentavalent vaccine, which is given at 6 weeks, 10 weeks, 14 weeks, along with polio vaccine as well. And also pneumococcal vaccine, they go on the same schedule. Rotavirus is a 2-dose vaccine given at 6 and 10 weeks. And then also looking at the measles vaccine, which is given at 9 months of age. And okay. So the vaccines that are being delivered, and then we look at basically characterize them by different characteristics. So in this case, by looking at socioeconomic characteristics. So looking with respect to ethnicity, for example, Tigray ethnicity has a much larger coverage compared to the Somali ethnicity. And here, for example, we can look at by geographic characteristics. And here the cities of Dire Dawa and Addis Ababa have a much larger coverage. And we can also characterize by with respect to, in this case, maternal education. And in this case, for example, mothers who have secondary education have a higher coverage. And then with respect to child characteristics, it's not that much of a difference, but if you are a child that is born within the birth order, first 3 children, then you have a relatively higher coverage. But this is by looking at a simple with respect to pi variant using a simple logistic regression. And then here, the corresponding impact, as we can see with respect to, especially the cities have a much higher coverage, and then the more rural areas, in this case, Afar has a much lower coverage. And then when we do adjust them, when you do the adjusted associations, the ones that do come out as showing more prominent with is the wealth quintiles have to have a significance. So children belonging to households of a more wealthy households, they have a higher vaccination coverage. And it's kind of interesting because there's no out-of-pocket payment to access vaccination in Ethiopia. So it's not just the out-of-pocket payments. There are other aspects that are in play that are acting as barriers to get the vaccination. Then with respect to region, again, like many of the more urban regions have a much higher coverage. And with respect, again, maternal education, like secondary education or higher is a higher coverage. And with respect to household head, which was kind of contrary to expectations, actually female-headed households had lower, children belonging to those households had a lower coverage compared to male-headed households. And the other aspects didn't really have that much of a significance, the birth order or the gender of the child or maternal age, or with respect to the broad categorization of rural versus urban. But when you look at the provincial level, you do see differences. So the key aspects is, when instead of looking at vaccination coverage nationally, if you can disaggregate it and look at it from different characteristics of the subpopulations, then we can basically identify populations that have a much lower coverage, especially coverages that are much lower than herd immunity levels. So these are the populations that should be prioritized for vaccination correspondingly. And then coming out to the current context of, in the current context of COVID-19 pandemic, immunization programs in many countries have been disrupted, both routine immunization programs as well as campaign immunization programs. And in fact, around March, all campaign immunization programs were suspended. And with respect to the coverage of routine immunization programs in many countries, it started to drop further. So in this context, trying to understand what is the disruption to the immunization programs in the context of the ongoing COVID-19 pandemic, and if you do continue those programs, what will be the corresponding impact with respect to both vaccine preventable burden as well as with respect to excess COVID infections that can take place. So you do comparison of the health benefits of sustaining routine childhood immunization, in this case Africa, against the risk of excess coronavirus infections acquired by visiting these vaccination clinics. And here we are looking for a period of 6 months. What if these vaccination programs are suspended? And here we look at the vaccines that are given at, like diphtheria, tetanus, pertussis, hepatitis B, hemophilia type B, which is a pentavalent vaccine given at 6, 10, and 14 weeks, along with pneumococcal vaccine and rotavirus vaccine. The first dose of measles vaccine is given at 9 months of age, along with rubella vaccine, meningitis A, yellow fever, and the measles vaccine is given in the second year of life, between 15 to 18 months. We did not look at the BCG vaccine, hepatitis B, or the polio vaccine. And with respect to the vaccine preventable burden, the health benefits are measured from immunization among the vaccinated children until 5 years of age. And the estimates for all of these vaccines are coming from the Vaccine Impact Modeling Consortium. So when you look at the probability of getting a coronavirus infection at the clinic, and also while going to the clinic, what is the risk of potentially getting infected during travel to the clinic and back to the clinic? And then based on that particular probability, you extract those infections that are in excess of what could have happened. So these are infections these are new infections that is primarily attributable only to the vaccination, and which could have been avoided if that particular child and the caregiver, their parent, did not go to the vaccination. So that's the basic principle on which you estimate these excess infections. And then we can compute the benefit risk ratio. So the benefits is going to be the vaccine preventable deaths that are averted by vaccination. And the risk is that excess COVID-19 deaths attributable to coronavirus infections acquired during those vaccination visits. And the benefit risk ratio larger than 1 indicates in favor of sustaining the routine childhood immunization program even during the COVID-19 pandemic. So thereby, when I look at the impact of the vaccines that are delivered in the first 3 visits, basically 6 weeks, 10 weeks, and 14 weeks. So the vaccines that are given DTP3, hepatitis B, hemophilia type B, pneumococcal vaccines, and the rotavirus vaccines at the household level. So the risk at the household level is estimated as if either the child or the parent actually get infected. We presume that even the whole household could potentially get infected. So it's kind of a very extreme scenario where we think even if anyone is infected, the whole household could potentially get infected. And then even under such extreme scenarios, continuing routine childhood immunization is actually very favorable to the households, with almost 14 to 261 vaccine preventable deaths that can be averted for every 1 excess COVID-19 death. And then with respect to, when you look at only from the respect to children, the benefits are even more larger because the benefits of vaccination is primarily to the children, the vaccinated children, but the risk of COVID among children is very low with respect to both hospitalizations and deaths. Thereby, for every almost 5,000 to nearly 500,000 deaths can be averted among children for every 1 excess COVID-19 death averted due to suspension. And then with respect to the 4th visit, we are looking at measles, rubella, meningitis A, and yellow fever. You kind of see a similar pattern. At the household level, almost like more than 100 deaths could be averted for every 1 excess COVID-19 death. And the benefits are much larger when you look at just only the vaccinated children. And then when you look at the vaccine, 2nd dose of measles given at 2nd year of age, you kind of, since it's only 1 vaccine, and this is a incremental impact of the 1st dose of vaccines, the 2nd dose of measles, and we are looking at roughly 2 to 45 deaths can be averted at the household level for every 1 excess COVID-19 death. And when you look at specifically the vaccinated children, again, the impact is much larger. So when you combine the vaccines that are given in the 1st year and 2nd year of life over a 6-month period, if we do continue these vaccines, all of these put together, we can potentially avert between 14 and 267 deaths for every 1 excess COVID death attributable to continuing the immunization program. And when you look at the impact with respect to vaccinated children, it's much larger, as again restating it, because they are the primary beneficiaries of vaccination, while the risk of COVID is much less. And then in comparison, we took a much more extreme scenario, wherein because of the current levels of herd immunity or the current existing coverage, in the next 6 months, we will not see any vaccine preventable disease outbreak, except for a small chance of a measles outbreak, roughly around like 12.5%, like 1/8 of a chance of a measles outbreak, but no other vaccine preventable disease outbreak. Thereby, if we do continue the vaccination program the next 6 months, the impact is only going to have some impact on the measles vaccination, and no other outbreak of the other antigens are going to take place. And even under such extreme scenarios, the benefits to the vaccinated children are much higher. And at the household level, except for like 4 countries, which is basically Morocco, Tunisia, Egypt, and Swaziland, pretty much all other countries still it is a favorable scenario to continue routine immunization. But that being said, there are other factors that should be taken into account in the decision-making process, such as the logical constraints of vaccine supply chain problems and reallocation of immunization providers to COVID-19 and other health services, and healthcare infections that can, or coronavirus infections that can take place among the healthcare staff. And also, if healthcare staff are infected, they can potentially transmit onto their households and the wider community, as well as from the demand side, wherein many community members' families may not want to visit the vaccination clinics for fear of contracting coronavirus infections, and as well as ongoing rumors and misinformation, which decreases the demand. But that being said, we'll have to counterbalance with the, like similar to the concept of opportunity cost, what is the opportunity risk of continuing routine immunization? If the healthcare staff, if they are not providing immunization, what other alternative activities they'll be providing? If those activities have higher risk of coronavirus infections, then it is actually beneficial for them to continue the immunization program rather than other activities. And with respect to the children, again, if the children and their parents are going to be involved in alternative activity, instead of visiting the vaccination clinic, which has a higher risk of coronavirus infection, and it's definitely beneficial for them to go get the vaccine, because one, they're involved in a much less risky activity of COVID-19 infection, as well as vaccines are highly beneficial for the children. So with respect to the implications for policy and practices, child immunization programs should be safeguarded and should be prioritized to continue even during the COVID-19 pandemic in Africa. But that being said, it cannot be business as usual. The current immunization service models we need are going to be adapted. So wherein physical distancing measures are put in place, personal protective equipment, and good hygiene practices, so that any risk, or like so that to lower the risk of coronavirus infections while still continuing to provide the immunization services. In essence, there's really no zero risk strategy. So there is going to be some element of risk, but the benefits are so overwhelmingly high. The benefits, when you compare the benefits and risk, overall it's beneficial to continue the immunization program. So to start off, we looked at the effectiveness in the context of HPV vaccination at the global, regional, national levels. And then those estimates actually feed into adding the cost on top of it, and specifically looking at Gavi eligible countries. There are a number of countries wherein without the Gavi subsidies, it will turn out to be not cost effective. Wherein potentially introducing HPV vaccination could replace much more efficient healthcare services. So that needs to be taken into account. And then with respect to the dengue vaccination, which is currently suspended, wherein when the test does become available, correspondingly how to do the cost benefit analysis in order to make it like beneficial, as well as making sure there's a positive return on investment. And with respect to the equity aspects, like instead of an aggregated national level coverage, when you look at more disaggregated level, both on the spatial front as well as on socioeconomic and maternal child characteristics, then we can identify subgroups that could be prioritized, and more targeted vaccination strategies need to be put in place to improve the coverage among the subpopulations. And then finally, we looked at the benefit risk analysis, wherein in the ongoing COVID-19 pandemic, it's highly beneficial to continue the routine child immunization, even though there's some element of risk. When you do the benefit risk comparison, it's highly favorable. That being said, so thanks very much for Jess, Stephanie, and Wilbert for arranging this seminar. And thanks to all of this work that has been presented is in collaboration with colleagues in the Infection Monitoring Center, the Vaccine Center, and the Health Economic Centers. And thanks to all of you for listening. Thank you very much.
Thanks so much, Dr. Abbas. It looks like we already have a question. Angel, I'm going to go ahead and unmute you if you want to go ahead and ask your question.
Do you hear me, Jess?
Yes.
Thank you. Kava, thank you so much. This is Angel. Good for you to be in Korea, but I have a few really major questions about the benefit risk analysis. And the main thing is that it's not a dynamic model according to the paper in Lancet. So the effect of the vaccines that were applied before the pandemic is not included. Additionally, the RT, the effective reproductive number of each disease may be decreased by the non-pharmacological interventions that are going on right now for COVID-19. So are two major aspects of the work that are unaccounted for. I don't know if you have congrats.
Yeah, so that was kind of taken into account in the other scenario where we implied only measles vaccination is going to have an impact, no other outbreak takes place. That's a kind of like a scenario that's replicating where many vaccine preventable disease outbreaks may not take place, or at least the risk is much lower in the context of the physical distancing measures that are put in place. And then also, even with respect to measles outbreaks, we also assume the risk is even more lower, almost like altogether 12.5%. But in the absence of vaccination, measles outbreaks will take place every 2 to 4 years in each of these countries. And so with potentially what we do put in a scenario is what almost reducing even by 50%. Like if thought this, it's around 4 to 8 years, and then a small chance of it within the next 6 months, such an outbreak is taking place. So it's kind of taking reduced risk of vaccine preventable disease outbreaks taking place in the near future. And even in such scenarios, it's still beneficial to continue the vaccination currently when compared. There's a risk, but the risks are much lower with respect to COVID infection.
Yeah, that's the point, and I'm ending with this. The scenarios that you put on are, from my view, are not really realistic, and it hasn't been seen yet in Africa. And so the focus of the paper is the focus will diverge resources from COVID to another diseases. I agree fully that the vaccination must continue, but the paper, the analysis needs to have more realistic scenarios that I don't see currently. I think.
Yeah, that's a kind of a good comment. And with respect to the COVID outbreak scenarios, they are a little more extreme than what we have seen so far. And when you incorporate the more current estimates, the benefit risk ratios will actually be even more favorable compared to the kind of estimates that we have in the paper is actually quite conservative.
Okay, great. It looks like we have another question. I'll go ahead and unmute them so they can ask.
Hello.
Hello.
Yeah, I'm calling from West Africa. When I look at your modeling, you are really trying to get reflected HPV coverage. But then, as you mentioned it earlier on, the strategy, the global strategy for cancer eliminations has three key areas, one of which is the screening. And then what about adding the screening on top of the HPV vaccination in terms of impact in that modeling? Over.
Yeah, like we didn't specifically look into that, but that has been done as part of the global cervical cancer elimination strategies. So there are 3 different models that do look into that. Like, so one is the Harvard model, the other one is the Mark Brisson model, the third one is the Karen Grenfell model. So they look into both vaccination and screening and the combined impact. What we did look into is only the impact of vaccination.
Great. Are there any other questions? You can raise your hand in the chat if you have a question, or type it into the chat, or put it into the Q&A box.
I have a question, Kaja. So thanks for the presentation. And my one thought was a lot of the immunizations are child immunizations, at least some of them that you presented. So how important is it going to be regarding COVID and continuing those about the different transmission rates in the different age groups? Have you thought about, I mean, there may be some that are more important than others, or some that are affected more than others by shutdowns and things like that? That's the first question. The second one is, how good is the information that you have from African countries about what is happening around COVID and around shutdowns and behavior changes, so that the immunization programs may be effective?
Okay, yeah. So primarily, like the work that was done was actually done in partnership with Gavi, Gates Foundation, as well as the WHO. So the work has already been presented to different stakeholders at the country level, and they are the ones who are making decisions on what they should be doing. And with respect to what has been happening currently, the current online discussions is look at catch-up vaccination strategies. So looking at the current impact, what has been the reduction with respect to routine immunization, what has been the impact with respect to reductions in campaign immunizations, and what should be the pragmatic strategies moving forward on catch-up vaccination. So that's the kind of ongoing discussions that is happening with country stakeholders, yeah.
Great, thanks. And so, but what do you have good information to go by regarding the impact of COVID on those programs? Or is there, because we see even for countries like the US, it's not always clear what's going on, and so I'm wondering, are you happy with the information that you're getting to make big decisions about vaccination programs resuming or not?
I mean, that's an underestimate all over. I mean, like, so that is true. But that being said, like, we provide this information, and then what the actual decisions are made is not just only looking at the health impact as well. There are other aspects that have been looked into in order to make those decisions. One is, of course, the larger economic impact, and also the impact of COVID on non-COVID health services. So they kind of looked into in a much more wider angle rather than a very specific, we only do immunization. So it's a kind of a broader discussion of COVID impact on non-COVID health services. And that is only one piece of the puzzle. With respect to governments, they have to look at other aspects as well, beyond health services as well.
Right, we have another question from Dr. Murray. So I'll go ahead and unmute you.
Hi, Kaja. Hi, I just had a question. I was wondering, what lessons do you think we can learn from this research and then apply to COVID-19 situation? If we are trying to have, trying to do high burden, high impact, then should we target the older population first if we have to prioritize vaccination?
You mean the COVID-19 vaccination?
Yes.
Okay, so that's going to depend on the, okay, first, that's also currently that's an ongoing open call, like for WHO, like wherein they're looking at different strategies. First, we don't know what type of vaccine will become available. Is it going to only stop the disease, but not the infection? And also whether the vaccine will have variable efficacy among different age groups. So if we have a vaccine that is more efficacious among younger population, then you may want to prioritize younger population, because by prioritizing them, even though the disease burden among younger population is not high, the indirect effects, the herd effects, could be beneficial for elderly population. On the other hand, if you have a vaccine that has almost uniform vaccine efficacy, irrespective of any age group, then the vaccine should be prioritized among the elderly first, because they have a much relatively more severe cases taking place, higher case fatality rates and so forth. They should be prioritized compared to this. But there's a whole set of scenario analysis of interest. I can share it with you. Yeah.
Okay, great. Thank you.
Okay.
All right. Are there any more questions?
Hi, Kaja. This is Stephanie. I was going to ask a question.
Yeah, sure.
So I think you mentioned that currently there are some countries in Africa where the immunization or the vaccination program has been suspended. So have we already seen, or when do you think we might see some data showing that there's been an increase in preventable diseases in children?
So one was what the recommendations from WHO in March was basically the routine immunizations should continue, but the campaign immunization program should get suspended. So the ones that are actually most affected because of the campaign program suspended are basically the measles vaccine, meningitis A vaccine, and yellow fever vaccines. So these are the three that has been suspended. And so far to date, we haven't seen outbreaks of these three outbreaks that much so far, at least to my knowledge. But that being said, there has been, okay, I should rephrase it. There has been some outbreaks that has been seen, and at least I do know of one in Nepal where the campaign vaccine that was supposed to take place for measles that has been suspended, and the numbers are actually going up. There are outbreaks taking place currently in Nepal, and there are a few more countries in Africa as well. I don't want to quote anything off the head, but there are a few countries that have been affected in Africa as well. And then in that context, what is currently happening is that when an outbreak is detected, then an outbreak campaign vaccination is implemented, or that is at least a strategy in place. Whether it gets implemented or not, it's like, we are not very sure. Yeah.
Okay, great, thank you.
Okay, well, if we don't have any more questions, thank you so much for your presentation. It was great. We will have the slides and this webinar recording on our website for anyone to access afterwards. Thank you all for attending. Is there anything else you'd like to say, Dr. Abbas?
No, thank you just for organizing all of this, and also Stephanie and Wilbert. And thanks to all of you. Yeah.
Of course.
Thanks, Kaja. Great to see you again.
Okay, sounds good.
Thanks,
Wonderful.
everyone.